Our next topic is acute respiratory. So normally we divide respiratory failure into hypoxemic and hypercarbic respiratory failure. So we'll first start off with hypercarbic respiratory failure. So generally, your PCO2 is it's proportional to the rate of CO2 production, and it is inversely proportional to the rate of CO2 expulsion. So hypercarbic respiratory failure is on a spectrum, and it goes from affecting your lungs to your upper airway, chest wall and pleura, respiratory muscles, peripheral nervous system, all the way to central nervous system. And this is also on the spectrum of how patients will behave. So when it's generally at the lungs level, can't breathe enough, if it kind of starts affecting your airway and your respiratory muscles, it's really you can't breathe. And once it gets to your central nervous system, you won't breathe. So causes of hypercarbic respiratory failure are anything that leads to decrease in minute ventilation. So this could be CNS depression, such as having sedatives, stroke, sleep apnea, or OSA. It can be a decrease in the thoracic or neuromuscular function. So this could be secondary to spinal cord injury, lower motor neuron injury, some metabolic disorders, as well as toxin-mediated. It can be due to an increase in dead space. So for example, shallow breathing, or if you have PE, vascular disease, or more end-stage interstitial lung disease. And it can also be due to an increase in CO2 production. So for example, with fevers, thyrotoxicosis, or sepsis. Next, we'll talk about hypoxemic respiratory failure. And this is anything that leads to a decrease in alveolar ventilation. So you can have diffusion abnormalities, such as ARDS or pulmonary fibrosis. You can have a ventilation perfusion mismatch, such as in pulmonary embolism or even pneumonias. And you can have an AV shunt, such as an anatomic ventricular septal defect or an intrapulmonary arteriovenous shunt. So now we've talked about some causes of hypoxemic and hypercarbic respiratory failure. And in the ICU, it is our job to determine whether or not a person needs mechanical ventilation. So some of the things that will lead us to pursue mechanical ventilation are 1, airway protection. So if a person has a physical trauma to their airway, or they have decreased sensorium, or what we often say altered mental status. If they're having increased work of breathing, because that will be impending respiratory failure, or something that shows acute hypoxemic or acute hypercarbic respiratory failure. Now note, for hypercarbic and hypoxemic respiratory failure, you do not need a particular PCO2 or PaO2 that says this is when you're going to put a person on a mechanical ventilation. You have to see the person as a whole. So there's a few types of ways that you can set up mechanical ventilation. And when you do so, there is mode versus type. So first we're going to go through some of the modes of mechanical ventilation. So the first ventilation mode we will talk about is ACCMV, or continuous mechanical ventilation. You will see that most of our patients in the ICU are on this mode because it is a full support mode. You can set the respiratory rate, tidal volume, and PEEP. One of the disadvantages of this mode is that it can lead to breath stacking and auto-PEEP. This occurs in patients who require a longer time to expire the tidal volume that is delivered. Therefore, with every breath, some tidal volume will remain, and thus, if you have greater volume and your lung does not recoil to its normal and expiratory phase, you will generate an auto-PEEP. The way to find this out is to do the end expiratory hold, and you can measure the PEEP minus the PEEP that is set and determine if the patient has auto-PEEP. And why do we care about this? Because high levels of pressure will eventually cause barotrauma. Second type of ventilator mode is SIMV, or synchronized intermittent mandatory ventilation. This is similar to AC in that you can set the respiratory rate, tidal volume, and PEEP. However, in this, the patient can also trigger their own breath, and when they trigger their own breath, they do not necessarily get the full tidal volume. Unlike CMV, in which with every breath you get the full tidal volume. The disadvantages of this mode are that it can lead to an increase in work of breathing. Another mode that we commonly use is the PSV, or the pressure support ventilation, more commonly known as CPAP. You will see often that, why don't you CPAP the patient? In this mode, the patient will initiate their own breath, their own rate, and their own tidal volume, and this is often used to determine the readiness of extubation. This, you can actually control the pressure that you give. Therefore, as you're trying to wean someone off the ventilator, you can provide them with a little extra pressure and start to come down on the pressure as they're getting better and better. So as far as ventilation types go, you can do volume control, pressure control, or PRVC, which is pressure regulated volume control. PRVC is a little different in that the ventilator or the patient can initiate the breath and at a constant pressure like that of pressure-controlled ventilation that is applied through both mechanical and patient breaths. The ventilator monitors each breath, comparing the delivered tidal volume with the set tidal volume, and then adjusts the inspiratory pressure to achieve that set tidal volume. If the delivered tidal volume is too low, then the inspiratory pressure of the next breath is increased, and if it's too high, the pressure of the subsequent breath is decreased. The advantage is that this is a continuous response to a change in airway compliance, because with each breath it can change the pressure. But the disadvantages can be hyper or hypoventilation when there are changes in lung resistance or compliance. So this is mode plus the type of ventilation. So as you can see, the most common thing we will use is the first one, which is AC or CMV, Assist Controlled Continuous Mechanical Ventilator, with VCV or Volume Controlled Ventilation. And here you can pretty much put in any combination that you would like, but the most common will be Assist Control, Volume Control Ventilation. Now, other than invasive mechanical ventilation, there are non-invasive mechanical ventilation, which includes CPAP, BiPAP, and AVAPs. So before we go into each one of those, we must look at the contraindications of non-invasive ventilation. The first one is if there is an uncooperative patient. This could be anything from an anxious patient to an obtunded patient. Second is physical trauma to the face. Third is if a patient is having copious secretions. Fourth, if a patient is vomiting. And fifth, if they've had any surgery that's going to affect the airway, such as facial, esophageal, or gastric surgery. So CPAP is continuous positive airway pressure, which is similar to PEEP. When you use CPAP, patients must initiate all of their breath and they get delivered a positive airway pressure. The indications for this are obstructive sleep apnea, congestive heart failure, and to wean off invasive mechanical ventilation. Now, congestive heart failure, often in the hospital, we use bilevel instead of just CPAP. However, CPAP is sufficient because you need only really the positive pressure to help move fluid out of the interstitium. Bilevel positive airway pressure, you can set two different pressures, the IPAP and the EPAP. And the difference will help correlate to the tidal volume. So having two pressures to set versus one in CPAP allows for better ventilation. So the indications for this would be hypercapnic respiratory failure, pneumonia, however this is case by case, post-extubation, or pre-intubation. AVAPS stands for Average Volume Assured Pressure Support. And what AVAPS does is it changes your IPAP to meet the necessary tidal volume. So This is advantageous in patients who either cannot tolerate CPAP or BiPAP, or patients who are having continuous changes in lung compliance or changes in resistance because the IPAP is continuously changing. So you will see this will be useful in patients who have obesity hypoventilation syndrome or some sort of restrictive lung disease. So IPAP will change to attain the targeted tidal volume in this mode of ventilation. So I just want to talk a little bit about BiPAP settings. So like I said, we don't really need to use BiPAP in CHF, but we often do. So we can start off with the IPAP EPAP 10/5. And note that these incremental increases are both in IPAP and in EPAP. So really, you need to aggressively bring up the EPAP to achieve a good mean airway pressure. Otherwise, you can just use CPAP alone. Now for BiPAP and other things such as acute hypercarbic respiratory failure, you're really trying to look at the difference between the IPAP and the EPAP. So the difference between the IPAP and the EPAP is the driving pressure, and that will support your work of breathing. So that too you can start at 10/5, and then if you increase that like BiPAP to 15/10, you haven't really changed the driving pressure. So you want to increase the IPAP and usually leave the EPAP alone or increase it just slightly so that you can increase the driving pressure. So now I'm going to talk briefly about mechanical ventilation settings, how to initiate the initial settings of mechanical ventilators, and how to navigate the ventilator screen for information. Here we're going to go over some initial ventilator settings for 3 scenarios. So first we'll start with normal lungs. So the goal in normal lungs is to ensure a lung protective strategy and essentially do no harm. So volume here will be about 8 milliliters per kilogram. To note, this is per kilogram of ideal body weight. So you must get the patient's height and calculate their ideal body weight in kilograms multiplied by 8. The rate you set about our normal breathing rate, about 10 to 12, a PEEP of 5, and an FiO2 of 100% that you can down titrate as tolerated. For asthma and COPD, your goals are to ensure that patients has adequate oxygenation, they have adequate exhalation, and they avoid breath stacking. So similarly here, your volume will be about 8 milliliters per kilogram, but your rate will be a little bit less, about 6 to 10, PEEP of 5, and FiO2 of 100%. Now in ARDS, it's a little bit different because your goals are to ensure that you can get as much recruitment as you can of alveoli, to avoid atelectasis, and to achieve adequate oxygenation. So here, your volume will be lower, 6 milliliters per kilogram, a rate of about 10 to 12, and your PEEP will be significantly higher. You can start around 8 to 10 and work your way upwards as needed. Your FiO2 here will also be 100%, and you will titrate as a patient can tolerate. So one of the most important things is that once you put a patient on a ventilator, you must get an ABG at least 30 minutes afterwards to see what their pH is, to see what their CO2 is, and to see what their oxygenation is, and adjust the ventilator as needed. So now we're going to take a look at the mechanical ventilator, and this is one of the kinds that we have in the ICU. Most things are labeled, but I'm just going to point out a couple of important things so that we can be oriented when we go to the ICU. The first thing here is this big knob. When you click any of the parameters on the screen, you can use this knob to make your necessary adjustments. Now, along the bottom of the screen are the things that we as providers can set for the patient. So to the far right is the FiO2. Here is usually the PEEP. This is the tidal volume, and this is the rate. Along the left side is what the patient is doing. So over here is the patient's tidal volume, this is the patient's rate, and this is the patient's peak pressure. Then this loop is the pressure loop, This loop is the volume loop. So these are kind of the most important things that you would want to look at, especially when you're evaluating your patient in the morning. We want to often see that are the things that we set what really the patient is doing. If you look in this patient, the rate is set to 8, but the patient's rate is 12. So we can tell that the patient is overbreathing the ventilator. So a few things to remember. Ensure you pick the settings on a ventilator specific to the patient's condition. You must obtain an ABG after 30 minutes of your initial settings, and you repeat an ABG every 30 minutes until your ventilation goals are met.